This is the oral squamous cell carcinoma, a type of oral cancer originating from the squamous cells of the oral epithelial tissue. The squamous epithelium is a thick, stratified layer of cells, with large and flattened mature cells towards the surface. OSCC represents over 90% of oral malignancies. It is usually asymptomatic, especially in the early stages, and it commonly appears as an ulcer, a red or white patch from a pre-malignant lesion, or even as a lump in areas such as the tongue, floor of the mouth, and lips. That is why I recommend you to go back to the videos of ulcerated lesions and white lesions to review all clinical presentations and variations of this very important lesion. Now today, we are going to review all the etiology, diagnosis, and treatment of the OSCC. Take a look.
All right, welcome everyone. We're going to jump right into a really critical clinical update on oral squamous cell carcinoma. As dental practitioners, we are truly on the front lines of detection. What we spot in a routine exam, well, it can literally change a patient's life. Let's kick things off with a single number that shows you exactly what's at stake.
38%. That's the 5-year survival rate for patients who are diagnosed with advanced oral squamous cell carcinoma. It's a pretty grim number, and it's a stark reminder of why we're talking about this. It just highlights this incredible window of opportunity that we have for early detection. The difference between spotting something early versus late isn't small. It can be everything.
So, here's how we're going to break this down. We're going to walk through the complete diagnostic journey. We'll start with the risks and those all-important precursor lesions. Then we'll get into the nuts and bolts of diagnosis with biopsy and imaging. After that, we'll look at some of the amazing new treatments on the horizon. And finally, we'll wrap up by focusing on what is arguably the most important piece of the puzzle, your role in all of this.
Okay, let's dive into our first section. To really get a handle on OSCC, we have to understand the why behind it. This is all about knowing the key risk factors and, even more importantly, recognizing those precursor lesions that you and I are in a unique position to find.
Now, we all know the usual suspects, right? Tobacco and alcohol are at the top of the list, and we know they're even worse when used together. But it's also so important to ask about other habits, things like betel quid chewing, and keep an eye out for shisha smoking, which a lot of patients mistakenly think is harmless.
And this is where we become absolutely vital. See, those risk factors don't just flip a switch and cause cancer. More often, they create these clinically visible changes we call potentially malignant disorders, or PMDs. Spotting these is our best chance to get ahead of the disease before it even starts.
Okay, take a look at this. These are the key PMDs you've got to have on your radar. We're all trained to look for leukoplakia, that classic white patch, but it's erythroplakia, the red one, that should really set off alarm bells. A staggering 91% of these red, velvety lesions, they already show severe dysplasia or worse on biopsy. That fact alone makes being able to spot a red lesion one of the most vital skills you can have.
So let's say you've identified a suspicious lesion. What's next? Now we move into the how of the investigation. This is all about confirming our suspicions and staging the disease so we can figure out the best way to treat it. We have all this new tech coming out, salivary tests, advanced lights, but this quote just hits the nail on the head. At the end of the day, the incisional biopsy and the pathology report that follows, that is still the undisputed gold standard. It's the only way to know for sure. So, once you've got that definitive diagnosis, the next huge question is, how far is it spread? And this is where imaging becomes absolutely critical, especially when we're trying to figure out if the cancer has invaded the mandible. And that brings us to a tool that I know many of you have right in your practice, the cone beam CT. It's accessible, gives us great detail, but how good is it really for this specific, critical task? Well, a recent systematic review gives us some surprisingly specific answers. First, the good news. When it comes to the simple binary question, is there bone invasion, yes or no, CBCT is perfect. It has 100% accuracy in figuring that out when compared to what we see under the microscope. But, and this is a big but, its reliability takes a major hit when we ask a more detailed question. When it comes to evaluating invasion of the inferior alveolar nerve, which is so important for surgical planning, the accuracy plummets to just 69.2%. That's a pretty big margin of error that we have to be aware of.
And this number, this has huge implications for surgeons.
The study found that CBCT, on average, underestimates the true boundary of the bone invasion by almost 3 millimeters. Think about that. That 3 millimeter gap could be the difference between a clean margin and leaving cancer cells behind.
So the bottom line here is pretty clear. CBCT is a fantastic first-line tool to just confirm that bone invasion is present. But we have to respect its limitations. It's not as reliable for nerve involvement, and critically, surgeons have to plan for that boundary underestimation by building in a safety margin.
Okay, let's shift gears. Once a patient is diagnosed and staged, what's next for them? This is an area that's just exploding with innovation, moving way beyond the traditional treatments we're all used to hearing about. The whole treatment landscape is changing before our eyes. We're moving from these broad, sweeping approaches like surgery and systemic chemo to really precise molecular-level attacks. We're talking about targeted therapies that block specific growth signals, immunotherapy that unleashes the patient's own immune system, and even nanomedicine.
Nanomedicine is one of the most exciting frontiers, for sure. The concept is just genius in its simplicity. Instead of flooding a patient's entire body with a toxic drug like cisplatin, you use these tiny nanoparticles to deliver the medicine right to the tumor. You get a massive dose right where you need it with way less collateral damage.
And the results are pretty staggering. A recent trial for a nano-engineered cisplatin patch called PRV-111 that's applied directly to the tumor, it showed an over 87% response rate. And here's the kicker, no serious drug-related side effects. This could be a total game changer, especially for shrinking tumors before surgery.
What's wild is just how fast this is all moving. I mean, look at this timeline. Just in the last few years, we've gone from targeted therapies showing some benefit to using powerful immunotherapies before surgery to prime the immune system, and now we're seeing combination therapies that are getting a major response in 40% of patients. These are powerful new options for people who just a decade ago had very few.
Okay, let's bring all of this home. We've gone through the risks, the diagnosis, the incredible new treatments, so now let's focus on the single most important part of this entire process, your role.
It really all boils down to this. All the advanced science and brilliant treatments in the world can't fully make up for a late diagnosis. What you do during a routine exam, that can be the difference between a patient having a highly treatable disease and them becoming part of that grim 38% statistic we started with.
And here it is, your playbook. 5 clear, actionable steps. It starts with just asking the right questions about risk factors when you take a history. It continues with doing a thorough oral exam every single time. It means trusting your gut to identify and document those PMDs, especially the high-risk red ones. And it ends with having the confidence to either take that biopsy or make an urgent, well-informed referral. This is our standard of care.
So I'll leave you with this question. Think about your first patient tomorrow morning. With this updated knowledge on risks, on what to look for, and on diagnostics, what are you going to do differently? How will you use this information to potentially change the entire course of their life? Thank you.